next is about gallbladder pathology. Now, gallbladder, as such, as you conventional anatomy of the gallbladder, I think you know very well. Like it's just in the below the liver, and the function is to collect the bile, and then concentrate. But there are a lot of anatomical variations. More than 40 varieties of the anatomical variations are recorded. So the standard anatomy of gallbladder, like cystic duct and the common bile duct, this may not be seen in many of the patients. You have plenty of variations where either the cystic duct may be connected to one of the hepatic ducts or the other way, midway, and so on. More than 40 varieties of these variations. Even gallbladder also either may be sessile or free, or there could be duplicate gallbladder, and so on. Variations are many. Now, we will not go into the details of those variations, but those variations are important when you operate upon the gallbladder, because you may not have that standard anatomy. Identification of these structures is one of the challenges during the surgical handling of gallbladder. Now, anyway, the physiology of the gallbladder is it collects the bile secreted from the liver and then concentrates, and as well as it modifies the contents. Now, whenever there is a need for the bile juice in the duodenum, that's duodenum, the food when it is reaching to the duodenum, when the food is more acidic and if it has to be made alkaline, then the CCKPZ, cholecystokinin pancreatidylamine enzyme, secreted by the duodenal glands, that stimulates the gallbladder to contract, and the gallbladder contracts and the bile is flown into the duodenum through the ampulla ureter. The sphincter would be acting as a gate wall, so that the bile would be secreted whenever there is a need for it. The bile is having alkaline pH, and hence it maintains the pH at an optimum level to the food which reaches to the duodenum, facilitating the absorption. At the same time, the bile also has a role to play with the fat the digestion and fat metabolism. I will come to that part later. So, secretion of the gallbladder is depending upon the CCKPZ, that cholecystokinin pancreatidylamine enzyme, which is secreted by the duodenal glands, and this cycle is maintained to maintain the proper pH acid. At the same time, some amount of the bile also may have a reflux into the stomach to keep the stomach pH at a moderate level, so it should not become very low. Identification of the gallbladder would be better done by the ultrasonography, and in the ultrasonography, the most important criteria of the assessment of a normal gallbladder, when you look at the normal gallbladder, is the location of the gallbladder and maybe the contents of the gallbladder. The contents of the gallbladder are homogeneous, and a normal gallbladder wall thickness is very thin and smooth, and it is not more than 3 to 4 millimeters. So that thickness is one of the important criteria, as well as the homogeneity of the contents of the gallbladder seen under ultrasonography is the important criteria to make out whether the gallbladder is normal or not. Now, gallbladder would be having a function of concentrating the bile which is secreted by the liver, reaches to the gallbladder and can remain there for a significantly long time, and the secretion of the bile into the gallbladder into the duodenum has two components. One of the major components which I have told is about the cholecystokinin pancreatidylamine stimulation. There is another component, the circadian rhythm. The bile will flow into the stomach at a higher concentration in the middle of the day and comparatively lesser at the night, and this kind of a circadian rhythm is maintained in the bile secretion, and this has something relevant to what we consider from Ayurvedic point of view as Vayoho Ratri Uttanam Teyantamadhyadiga Kramada. The doshas changes according to the situation of the food, cholecystokinin and pancreatidylamine relationship, as well as the daytime, like day and night, the circadian rhythm. Anyway, that's one part. Now the other part is about the contents of the gallbladder bile would be slightly varying from the contents of the bile secreted by the liver. The water content in the liver bile is higher, whereas the concentration becomes concentrated significantly in the gallbladder, the water content is reduced. bile salts contents are increased from 1.1 gram to 6 grams, almost 5 times more. And the bilirubin, of course, is not also is concentrated. Cholesterol, one of the important is the cholesterol, is about concentrated by about 9 times from the liver bile. So liver also secretes the cholesterol, but the cholesterol is concentrated in the gallbladder by further secretion as well as to a certain extent by the absorption of the water, so that you will have more concentrated cholesterol. This ratio of concentrated cholesterol and the fatty acids, phospholipids, other phospholipids also has a significant role to play in the formation of the stones. When we go further in, you will come to that. Electrolyte concentrations also, the gallbladder would be one of the major area where chloride and chloride is reabsorbed to a great extent, and bicarbonates also are reabsorbed. So keeping the alkaline medium of the blood, gallbladder has a role to play. So significant amount of the chloride and bicarbonate ions are reabsorbed, whereas to a certain extent potassium and calcium are secreted further in the gallbladder. So gallbladder bile would have higher concentration of the potassium and calcium, whereas a lower concentration of chloride and bicarbonate, and this keeps the impact of the gallbladder over the system significantly. The most important part of the gallbladder, the other contents of the gallbladder, are what we call as bile salts. Bile salts are not single molecule. You have some variations of the bile salt, which is primarily salt of a cholic acid, and all these bile salts have a basic fundamental structure of the pentaerythritine ring, which is also the same as that of the cholesterol. So cholesterol, the word cholesterol, it has a sterol ring. That sterol is the pentaerythritine ring, 4 pentaerythritine ring structures, and this structure is modified by adding some molecules, and you will have the different names of these bile salts like cholic acid, cholic acid, and so on. Now all these bile salts have a saponifying effect. They can produce soap-like impact effect when it's dissolved in water, and because of that soap-like effect, the fatty substance like cholesterol can be converted into a micelle. So the most important functions of the bile are in the facilitation of digestion of the fat. See, fat molecules, they are water insoluble, whereas the bile salts, they would be water soluble to a great extent, and they would have a hydrophilic part and a hydrophobic part. The molecules of the fatty substances, hydrophilic substances, they are converted into a micelle where all the hydrophilic part would be towards the surface, and the hydrophobic part, that's the part which is having an affinity to water, is hydrophilic, and the component which doesn't have an affinity to water is the hydrophobic. So this is arranged in such a way that the hydrophobic components would be towards the center and the hydrophilic components will be towards the periphery, and this function is facilitated by the bile salts, which have the saponifying effect, and this complex of a hydrophilic substance over the surface is called as micelle. So formation of the micelle is one of the important parts in the absorption of the fat. Fat can be absorbed only in the form of micelles. Without that, the fat cannot be absorbed properly, and hence the bile has a major role to play with the absorption of the fat. And in addition to that, it also has a mechanism of removal of the cholesterol from this bile acid, and cholesterol transport in the bile and intestine also is facilitated, and hence it has a role to play with the maintenance of the cholesterol level in the plasma properly. The cholesterol level is significantly dependent upon these bile functions, gallbladder functions as such. It's not that the cholesterol level would be altered only when there is a gallbladder impairment, but a gallbladder function impairment can be one of the causes for the abnormal cholesterol mechanism maintenance in the body. Similarly, the bile keeps the concentration of all the substances in such a way that there will be no crystallization, and it also has a function of facilitation of absorption of the fat and fat soluble vitamins as such. These are the major functions of the bile as such. Now the same bile function is further described. Now the food is presented in a form of complex emulsion, and food has the fat molecules as well as the oil droplets, bile salts and lipolysis products, that substances which are otherwise broken down by the fat. Now these broken down fat substances, they would be having an inhibitory effect on the absorption, and the soap like activity of the bile salts keeps them away, keeps them at a lower level and forms the micelles, and the micelle layers are modified in such a way that they can be absorbed and the lipolysis substance are left over in the intestines so that they can be excreted out, and that's about the important function of the bile. Now bile salts, they are not completely excreted out. A good amount of the bile salt is reabsorbed and undergoes enterohepatic circulation. Bile salts are synthesized in the liver, and about half a gram of bile salt is synthesized in the liver per day, average around that, and the bile which enters into the intestines in the different areas of the intestine, small intestine as well as large intestine and the colon also, there would be reabsorption of the bile, and about 95% of the bile is these bile salts are reabsorbed, and only 0.5 milligram of the bile salt is excreted in the urine. So the urinary bile salt concentration is lesser. Of course, this information has a relevance to play with the understanding of the liver function test. Now, if the bile salts are not synthesized properly, bile salts are the products of the blood mechanism, the hemolytic mechanism. If the bile salts are not synthesized, then you will have the biliverdin, which is presented in the plasma as a prehepatic jaundice. If the bile salts are not secreted into the intestines, then the stools would be clay color. The color of the stools, like yellowish color, is produced to about 0.5 grams of the bile salt which is present in the stools, which gives that color to the bile and these stools. So we classify them as bile pigment as well as bile salts. They together they will add to the color, and if the bile is not secreted, then the color of the stools would be the clay colored acid. Now, if the bile is not reabsorbed, the liver would not be able to form the bile salts. Particular bile salts are reabsorbed significantly. If the bile salts are not reabsorbed, the liver would not be able to produce the bile salts to the same extent as it is necessary, which results in malabsorption conditions. In the malabsorption conditions, one of the complications of the malabsorption, particularly fat malabsorption, would be the bile salt enterohepatic circulation would be affected, which results in a vicious cycle of continuous impairment of the fat metabolism. Now, this enterohepatic circulation of the bile also is dependent on the circadian rhythm. I referred about circadian rhythm, like the whole bile is secreted into the intestines under the two control. One, the hormonal control, that's the CCK-PZ, and then the circadian rhythm, which gives that the bile into the stomach as such. And this helps in the normal help in the diet and fat feeding time, alcohol, drugs. These would be affected by the secretion of the bile would be affected by these. Even the circadian rhythm would be affected if the sleep disturbances do occur. All of these factors together can result in an abnormality in the gastrointestinal tract, and then it can result in the impairment of the barrier functions, like the whole stomach mucosa would be affected, which results in irritable bowel diseases, obesity, so on. Whereas the impairment of the bile reabsorption, that bile salt reabsorption in the liver, it can result in liver injury or non-alcoholic fatty changes in the liver, or even it's also considered to be one of the causes for the hepatocellular carcinoma as such. So the impairment of the bile secretion or impairment of the gallbladder secretion, which could be affected by altering these circadian rhythm as well as the hormonal regulation by overeating or abnormal food, can result in an indirect impairment of the functions of the liver or functions of the intestines, presenting with the various forms of the disease. And that's the importance of the bile secretion. Now, that's about the general basic issues about the physiology of the bile in brief. Next, we will directly go into certain of the diseases of the gallbladder. Now, among the diseases of gallbladder, one of the common disease is called as acalculous cholecystitis, inflammatory pathology of the gallbladder. In fact, incidence of acalculous cholecystitis, a cholecystitis without the stone is just around 10% of the total cholecystitis which you see. More than 90% of the cholecystitis which you see clinically would be having a stone either as a cause for the cholecystitis or as a result of the cholecystitis, and such a cholecystitis with the stones are considered as a calculous cholecystitis. Acalculous cholecystitis is when cholecystitis has occurred due to some bacterial infection into the gallbladder pathology area due to certain other specific causes, and this spread is mostly due to during the through the bloodstream, the hematogenic spread. And the causes for the acalculous cholecystitis are sepsis. If the patient has any septic pathology anywhere in the body, the same can spread into the gallbladder. Among those septic pathologies, the one of the important is the typhoid, Salmonella organism. Salmonella organism producing typhoid have a high preference to reach to the gallbladder, and they produce cholecystitis more frequently. Of course, any other organism, many organisms like Streptococci as well as Helicobacter, they also can produce the cholecystitis in large number. So, but sepsis, a patient who has a septic pathology anywhere has a risk of developing the acalculous cholecystitis. That's all important. Similarly, a patient who is on parenteral nutrition for a long time, like rail soup feeding for a long time, has a risk of developing cholecystitis. The reason is simple. A patient who is on parenteral nutrition would not have the same stimulation of the gallbladder as that of a patient who is eating orally. The CCK-PZ cycle would be affected, and hence the gallbladder would become less active. That dormant gallbladder or inactive gallbladder itself would result in stasis of the bile juice, and that itself can result in a cause this inflammatory pathology. Patients with the cardiovascular disorders also have a high risk of developing acalculous cholecystitis. Incidence is quite high, and the relationship between the cardiac functions and the gallbladder functions also are now known. When there is an impairment of the cardiovascular function, the immediate consequence would be the gallbladder motility would be lesser, and same can occur. Pregnancy also is a cause for the cholecystitis because intra-abdominal pressure is increased and it results in the stasis. So that's how the pregnancy can be a cause for the gallbladder pathology. Hepatitis also can be a cause for the acalculous cholecystitis. Diabetes mellitus also is known to have a high incidence of the acalculous cholecystitis. So reasons for the acalculous cholecystitis is a hematogenous spread of the infection, but that hematogenous infection of the spread of the infection can be triggered due to the other systemic causes. Now, clinical symptoms of acalculous cholecystitis: pain in right hypochondrium and tenderness in right hypochondrium are seen in every patient. 100% of the patients is a common symptom. So, pain in right hypochondrium as well as a tenderness in right hypochondrium, which is also called as a Murphy's sign, is one of the most common clinical symptoms. Then dyspepsia in the upper abdomen. Fever is also another of the most common clinical symptoms in case of acalculous cholecystitis. The other symptoms which could be presented are nausea, vomiting. Jaundice is very rare. Jaundice can occur in case of cholecystitis only when it has involved with the biliary system, the biliary canaliculi. Otherwise, it may not. So, jaundice is not a common symptom, but it is seen. And the referred pain in the back and shoulder also could be seen in some of the patients. Itching could be the other clinical symptom. A palpable lump is seen in only a few of the patients, and palpable liver also is seen in only very few patients. That's about the around incidence of the clinical symptoms of acalculous cholecystitis. The confirmation of late calculus cholecystitis is done by mainly the ESG or the CT. In the ESG and CT, it's mainly the thickness of the mucosal membrane. The normal thickness of the mucosal membrane is less than 4 mm, whereas in inflammatory condition, acalculous cholecystitis, the thickness becomes more, and depending upon the thickness, you may predict like what could be the outcome. Thicker the gallbladder wall, the chances of complications like a non-functioning gallbladder or being a result, this cause for the stone formation in due course of time, or other septic complications of the gallbladder can be more if the thickness is more. If the thickness is lesser, comparatively the risks are lesser. So that's one of the important criteria whenever you refer a patient about suspected acalculous cholecystitis. The USG report would giving you the idea about the thickness of the gallbladder wall, and that is one of the important criteria, as well as the content of the fluid, like whether the bile juice is uniform, having uniform lithogenicity, or having some residual substances or irregular hyperechoic substances. Then presence of the hyperechoic substances is more suggestive of a stasis, or what we call as a sludge formation. I show you that image also, and that would also make the prognosis poor. Ideally, CT is not required to make the diagnosis. Ultrasonography is more accurate, and you will always get the correct information about the pathology with the ultrasonography. But CT also shows the same issue: the gallbladder wall thickness, as well as presence of inflammatory changes outside the gallbladder. The inflammation outside the gallbladder can be made out, or any other complications can be better made out with the CT also. Now, bile which can become stagnated, biliary sludge is one of the complications, later issue of the acalculous cholecystitis. Either it could be a cause or it could be a effect, also both the ways. A stasis bile can produce a hyper or irregular echoic content in the gallbladder. So presence of the gallbladder thickness and the increased thickness, presence of the sludge. If there are maybe a few of the gallstones, a sludge is not solid, semi-solid substances, these are suggestive of a gallbladder pathology with ultrasonography. So ultrasonography can give you an idea like whether there is a sludge formation or not. A sludge formation makes the prognosis poor. General treatment principles in case of acalculous cholecystitis is usually acalculous cholecystitis doesn't require surgery unless there is a acute complication. Whereas calculus cholecystitis, the preference is surgical treatment in majority of the patients. So general treatment in case of acalculous cholecystitis is antibiotics, and whenever you prefer the antibiotics should be the ones which are secreted through the bile. So concentration of the antibiotics in the bile is a quite significant effect. Of course, we will discuss more about that when we discuss about the calculus cholecystitis later. So, and when it's analgesics, it's quite important that in all cases of the biliary pathologies, narcotic analgesics like pentazocine should not be given, because narcotic analgesics, they produce the spasm of the sphincter, the sphincter of OD, and if there is a spasm of the sphincter of OD, that increases the pressure of the bile within the system, and it can result in more complications. So one important precaution is analgesics to reduce the symptom of pain. If at all you have to administer, it's better to use antispasmodic substances, anticholinergic substances than the narcotic analgesics. Non-steroidal anti-inflammatory drugs also can be indicated, they can reduce the pain, but narcotic analgesics should not be administered. But that's about the general line of the treatment. But majority of the patients can be effectively managed in the absence of complications with the Mrityunjaya, Arogyavardhini and Kumaryas. We have plenty of patients who are treated, and there may be a need for supplementing with the IV fluids at times, or occasionally there may be a need for supplementing with the antibiotics if the patient's total leukocyte count is higher, the fever and the toxic symptoms are higher. That's about the calculus cholecystitis. The next of the complications, these diseases of the gallbladder would be gallstones. Now, gallstones as such are now in the present categorization, they are categorized into 4 categories. The first is a lithogenic state, where the stone is not formed, but there is a chances of the gallstone formation more. Conditions which favor the gallstones, they are now, you are able to identify these conditions now, and preventive steps can be taken, and hence that's also considered as one of the phases of the gallstones. Then asymptomatic gallstones. Symptomatic gallstones characterized by biliary colic or complicated cholelithiasis, where you have the complications like perforation, empyema, and so on. So gallstones now are studied under these 4 stages as such: the lithogenic state, asymptomatic gallstones, symptomatic gallstones, and complicated cholelithiasis. Now, as far as the lithogenicity, the stones being formed, how that lithogenic status, what are those factors which can precipitate the lithogenic factors? There are maybe the intestinal factors, hepatic hypersecretion, rapid phase transitions, gallbladder hypomotility, or there could be genetic factor. And the specific genes are identified which can enhance the lithogenicity. So lithogenic genes now are identified, and it tends to occur in the families. The intestinal factors which precipitate these lithogenicity are those conditions where the reabsorption of food, the bile salts is reduced, like irritable bowel syndromes, or consumption of the food which has more of fatty substances. That can also result in intestinal this reduced reabsorption of bile salts, which can increase the lithogenicity. The liver hypersecretions in case of this hepatitis, or if there is some other factor which can make the liver secrete more of the insoluble substances like the cholesterol, then the chances of the lithogenicity are increased. Then the rapid phase transitions are some medicines given, like cholesterol reducing drugs. Now patients who have hypercholesterolemia, higher level of the cholesterol in the blood, and when you give the drugs which help in excretion of the cholesterol, that can result in a rapid change in the condition of the cholesterol concentration, and these rapid changes can also trigger the gallstones, or it can enhance the tendency for the gallbladder to have the gallbladder pathology or stone pathology, or hypomotility, reduced motility of the gallbladder, which could be produced due to a previous surgery of the abdomen. Any patients who had undergone surgical treatment, particularly gastrojejunostomy, where the vagus nerve is removed, vagotomy is done, the risks of the stones are enhanced because the motility of the gallbladder would be affected. Similarly, the hypermotility also can occur if the patient is obese. Obesity can be a cause for that. Pregnant women can have gallbladder hypomotility. These are the factors which can produce the lithogenicity. In addition to that, the lithogenicity, that lithogenic phase, also can be identified by assessing the constitution of the bile. Now, this is about the bile, the relationship between the cholesterol level and the phospholipid level, which enhances the chances of the stone formation in the gallbladder. A lower cholesterol level and a relatively higher level of these phospholipids, these are considered as safe levels, where the chances of the stone formation are lesser. So this is based upon the graph, like if the cholesterol level is just around less than 10%, and the correspondingly the bile salts are around 40%, the higher concentration of bile salts, and there is a corresponding higher concentration of the phospholipids, chances of the stone formation are lesser. Or the other possibility where the stone formation are lesser would be a relatively higher concentration of the cholesterol and maybe phospholipids. Even if the bile salts are lesser, if the phospholipids are higher, then the chances of the stone formation are lesser. The tendency, like a concentration of the bile salts in between 20 to 40% and a higher level of cholesterol increases the chances of the stone formation, and that's what we call as the second phase. That's a higher degree answer. The third phase is where the bile salts are very moderately low, but the concentration of the cholesterol as well as the phospholipids are very high. The risk of these are quite high. So lithogenic tendency can be predicted by assessing the bile juice concentration, but this kind of a practice is not very popular in certain specific cases or in very chances where there is a high tendencies, like this can be used as a prediction method, though this method is not yet clinically popular, but in the experimental studies as well as in the research activities, this is done, and the mechanism of modifying the concentration of the bile or contents of the bile by administering bile salts in higher concentration as a therapy for the gallstones has become come into practice after this kind of a information. The stones are formed due to these factors. In addition to this, the stones also are formed due to the other factors. The other factors which can form the stone formation are, one is the hyper concentration theory. There are different theories of the stone formation. One is a hyper concentration theory. That hyper concentration theory is when the water insoluble substances like cholesterol level is higher and proportionately the water level is reduced. That can be a cause for the stone formation, or presentation of high levels of bilirubin salts like the hemolysis condition. That also can be, that's what we call as a pigments. That's also increases the concentration. So higher concentration can be one of the causes. The other causes are the Needus theory. There is another theory, is a Needus theory. That's in any solution, if any solid substance is presented over, then the crystals will be deposited over that solid substance, and that acts as a center, focus for the formation of the crystals, which we can see in any solutions. Now, this kind of a possibility in the gallbladder also can occur if there is any foreign body. The foreign bodies could be microorganisms, as in case of the typhoid or any other cyclic pathology or cholecystitis. The microorganism colonies can act as leaders, or it could be the mucosal membranes of the gallbladder which are destroyed during the inflammatory pathologies. Also can be cause for leaders. Then the third theory is the hypomotility. Hypomotility, as we have already referred to, where the movement of the gallbladder has become reduced and stasis has occurred, and that stasis has resulted in the stone formation. So anyway, that's about the theories about the stone formation. The stones which are formed in the gallbladder, they are categorized into three categories based upon their contents, and they are categorized as either cholesterol stones or mixed stones or pigment stones. Cholesterol stones are relatively softer, yellowish color, and they are larger in size, and they have a smooth surface. Surface will be smooth. When they are cut, you will see yellowish color as such. Whereas the pigmented stones will be having a dark color, having sharp surface and irregular shape, and they are content hard, very hard. Whereas cholesterol stones are softer. Mixed stones, they will have a faceted appearance, and they are usually multiple. Numbers will be multiple. Cholesterol stones usually are single. Pigment and mixed stones are multiple. Mixed stones will have a smooth surface and faceted appearance, like you can say that hexagonal or so on. And when you cut them, you can see this central zone where some space is there, and there would be layers of deposition which we can see. As in case of the wood, you see the annual rings, so similarly that ring-like appearance here. In majority of the mixed stones, there could be, the central area may have a small amount of the gas, and particularly if the needles of infective organism is the cause for that, then this gas may be presented. And this presence of the gas may be seen in an X-ray, and which we often use as a Mercedes benzene. The name Mercedes benzene seen in the X-rays of the stones is possible only when the gas is presented and the gas is seen over the X-rays. Cholesterol gallstones are essentially non-opaque to the X-rays. They are not opaque to the X-rays, and hence plain X-rays will not be efficient to make out the diagnosis of cholesterol stones. Mixed stones and pigment stones may be visible to the X-rays, and they constitute only a few of the patients. Mixed stones are forming only about 62% of the stones, whereas the cholesterol stones form about 84% of the total stones seen. The chemical content of these also are different, like the calcium content of a pigment stone is very high, and because of that it becomes radiopaque. Whereas calcium content of the cholesterol is very low and hence it is not radiopaque. And the other chemical contents are cholesterol content in case of cholesterol is obviously quite high, whereas bile acid content in case of a pigment stone is higher than others. So chemical assessment of the stone after removal also can give you a clear idea of categorization of the stones. The physical appearance of the stone, color of the stone, as well as the clinical course also can predict, and or ultimately a final decision can be made out by the chemical analysis of the stone after that. Now, the factors which protect against the gallstone formation, there are known substances now which are known to reduce the chances of the stone formation by facilitating these concentration of phospholipids and cholesterol in a moderate fashion and facilitating the movement of the gallbladder as a lifestyle. Now, following these as a lifestyle fashions are now considered as a standard protocol to reduce the lithogenicity. If you have identified a patient as a lithogenic tendency before the stone has been formed, then it can be prevented by either statins, ascorbic acid, or unsaturated fats given in the food and coffee. Vegetable proteins and nuts also are known to have a preventive effect on the lithogenicity, resulting in a stone formation. Incidence of the stone formation is having a demographic pattern. Comparatively, India is one of those zones where the stone concentration or incidence of the stones are moderately high. Not dark color, grey color, the risks are high, and here the incidence is comparatively lower, but not very low. So India comes under that moderate stone incidence conditions as such. Now, as far as the other causes, clinical causes of the stone formation, the most important causes. Now, whatever we have discussed is about the chemical issues. Once the stone is formed from the lithogenic stage, when there is a stone formation, which may be either symptomatic or asymptomatic, the risks or incidence is more related to obesity, pregnancy, or stasis in the gallbladder. Stasis in the gallbladder due to pre-existing pathologies. And the most important pre-existing diseases are either the cholecystitis, inflammation of the gallbladder earlier, acalculous cholecystitis is a cause for the calculus formation, or congenital variations, which also can reduce the flow of the bile juice, or previous handling, surgical handling, or as I told you about vagotomy. These also can result in the gallstasis. Drugs like many of the drugs, particularly those drugs which reduce the cholesterol level in the plasma, they also have a high risk of cholesterol level, the stone formation. Then of course the heredity. And usually in general, in majority of the textbooks, you will have a mnemonic of the gallstones like 5Fs, and those 5Fs are fat, female, fertile, and infertile. This is very commonly described by fat because it is more in the Caucasian population, as I told you, that area zones of the country where people are less pigmented, and the fat, this BMI of more than 30 kg per square meter and hyperlipidemia is the more common cause for the stone formation. Incidence of the stone is higher in such categories. Females, and particularly fertile females, where female has more than one child, because during the pregnancy the motility of the gallbladder will be affected, the stone formation risks are higher, and age of 40 is also considered to be high incidence as such. Now, accurate clinical findings of diagnosis of gallstones. Now, clinical gallstones are presented with asymptomatic. If a large number of gallstones are asymptomatic, you will know that the symptoms of gallbladder has a stone only when the ultrasonography is done for some other reason. The other clinical symptoms also could be wide varying as such, and hence the incidence of these symptoms are studied on a statistical basis. The most important issue is about the specificity of the symptoms. Patients who have episode of biliary polyp, the specificity is about 94%. Radiating pain radiating to the back and the shoulder, it's around 61%. Then a patient who has a tendency to use analgesics for this. Now, those who have episodes of pain and they tend to use analgesics on their own, and this that analgesics, particularly antispasmodic analgesics, it's seen in around 51 the specificity as such. Now, usually patients who have pain in abdomen, they would be taking the self-administering drugs like proton pump inhibitors or these so-called antacids. But those patients who are not relieved by that, but the pain is relieved only by the analgesics. That's what we call as a use of analgesics, and that's in around 51. It's more specific for in 51% of the condition. Patients having fat intolerance, consumption of the fat producing discomfort, is also another sign which is more dependable. Then upper abdomen tenderness is seen in around 53% of the people. In general, anorexia, food intolerance also could be seen in around 57, and upper abdominal pain in 43. So the important is the whole course of a calculus cholecystitis may present without complications. Now, calculus cholecystitis presenting with the stones presenting without complications is the one criteria. With the complications is other criteria. We discuss about the stones which are presenting without complication. A large number, more than 60% of the patients will be asymptomatic. There will be no clinical symptoms. Only when you do the ultrasonography, you will know that the patient has a stone. The remaining, they may have any of these symptoms, and hence the accurate clinical diagnosis is always difficult. The better mode of diagnosis is always ultrasonography as such. Plain X-rays are not productive. As I said, the plain X-rays would be positive only when the patient has either a pigment stone which is opaque to the X-rays, and in the plain X-rays, the classical clinical sign of Mercedes-Benz sign, which is mentioned in the textbooks, are seen only in a very few patients. So plain X-rays having a very less benefit in diagnosis of gallstones. Ultrasonography is rather more accurate, where you can identify the stone as well as the impact on the gallbladder wall mucosa, and ultrasonographic information can be having a very good idea about the possible nature of the stone also, like comparatively these cholesterol stones would be bigger in size, and they are usually large in size, and they would be floating. And also the other information which we can get with the ultrasonography is whether the gallbladder is functioning or not. A stone in the gallbladder can result in a non-functioning gallbladder, and in a non-functioning gallbladder there will be lesser amount of bile or no bile at all, and hence the stone becomes fixed to the membrane. Whereas if the gallbladder is functioning and the bile is present, the stones may be floating over, and these floating stones also can be made of, say, a typical mixed stones where you have that hexagonal appearance seen in the ultrasonography. So ultrasonography is a better tool, and MRI scan also can give you an idea, but ultrasonography is a better tool to make the diagnosis. Now, to make the diagnosis of gallstones, the standard protocol, the general advice of the standard protocol is ultrasonography is having the high specific activity. More than 98% of the conditions can be made out with the diagnosis, and the advantages are it's inexpensive, and first time test of the patient will be gallstones can be providing you have all the information about the complications like or other accompanying conditions like polyps and so on. The other investigations which could be done, which are not generally done, now majority of the conditions in our practical clinical field, we limit ourselves to the ultrasonography. But other options which are available, which could be done, are more specific would be hepatobiliary acid scan, which also is considered to be very high sensitive and rarely it's done. So it's only from the theoretical point of view. MRI, of course, MRI cholangiography is also highly sensitive, but the sensitivity of all these sophisticated investigations are lesser than that of the ultrasonography. CT scan has still lesser sensitivity of 79%. When I say sensitivity, it means the accuracy of the findings. Then the sensitivity of this ERCP, endoscopic cholangiography, it will not be very high, but it is quite useful when the stones are supposed to be in the bile duct system and very small stones can be made out. So these are the other options of the investigations, but majority of the situations we limit only to the ultrasonography as the criteria to make the diagnosis. A calculus cholecystitis, a calculus asymptomatic stone, gallstone, can result in any of these complications later on, and these complications are what we call as a complicated cholecystitis can occur, and they are either biliary colic, which is a very common clinical symptom as such, cholecystitis, mucosal, empyema, fistula, perforation, carcinoma, syndromes of the Minice or Biliary syndromes, or choledocholitis, the stones in the common bile duct, inflammation of the gall system, enterohepatic stones, pancreatitis, and gallstone ileus can occur. We will not discuss all these complications separately, but we will refer to some of those complications which are important from the clinical point. Now, medical treatment guidelines. The gallstones, asymptomatic gallstones are uncomplicated gallstones. They are treated as a priority by medical treatment, and the medical treatment guidelines are usually ursodeoxycholic deoxycholic acid, that's a bile salt, is given at a high dose of 900 milligram per day, and it has a high benefit ratio if the stones are smaller, small stone size, that's 0.5 to 1 centimeter, and having good gallbladder function and no calcification. In these conditions, the medical treatment is advised. From our clinical point of view, I would use the treatment like Arogyavardhini and Kumaryasava, and the criteria could be even bigger stones. I would be preferring to treat the patients with bigger stones than the smaller stones. Bigger stones are safer because they would not produce an obstruction to the common bile duct, whereas the smaller stones, they have a risk of floating in and if they can block the common bile duct, they can produce a surgical emergency, and hence the criteria would be slightly modified in our treatment. And the exceptions for the expected management in persons with asymptomatic gallstones, this is what these modern science would say, the standards guidelines for the assessment. Whereas from my experience, gallbladder wall thickness of more than 8 mm, I would not prefer to have a medical treatment, prefer to go for surgery. Recurrent cholecystitis, patients who have episodes of recurrent cholecystitis also are another of the indications for the failure or limitations of the medical treatment. So medical treatment would fail if these conditions are there, and the current criteria would be calcification of the gallbladder, which we call as a post-line gallbladder, patients who have hemolytic anemia, and very large gallstones like more than 3 centimeters also is one of the these inhibitory factors or exceptions for the conservative management. And of course, this is another issue, global issue, Native Americans, because they have a high genetic risk of cancer development. And if the patients are having some other reason for the liver transplantation, this of course not relevant in our condition, but I have just added this because these are the universal gallstone, these universal guidelines. Small gallstones, as I told you, also are high risk of developing either common bile duct obstruction or pancreatitis. Other treatment, now the surgical treatment is the other option. With the surgical treatment for the gallbladder also, till very late, that is up to about 19th century, gallbladder was considered as one of the essential organs, and removal of the gallbladder was not really considered as a standard protocol of the treatment. Only in 1882, it was proved that gallbladder can be removed. Now, the whole history of that cholecystectomy is initially the cholecystectomy was done accidentally. A surgeon who was doing cholecystostomy accidentally removed the gallbladder, and to his surprise, that patient survived. And after this, they started experimenting on that, and then Langenbuch, one of the French surgeon, he developed that technique and presented a paper on the safe cholecystectomy, and from then onwards a open cholecystectomy was practiced. The present surgical protocol of cholecystectomy was introduced in 1882, And in 1985, a laparoscopic cholecystectomy was done for the first time. And now, on an average, more than 12 million cholecystectomies are done annually throughout the world, and the number of laparoscopic surgeries have increased remarkably than the open cholecystectomy. So now the standard protocol now has become laparoscopic cholecystectomy. This is about the year-wise increase. Year-wise, the number of laparoscopic cholecystectomy have increased remarkably, whereas the open cholecystectomies have reduced remarkably as such. That's about the principle of treatment of gallstones. So with this we will end up today. Tomorrow, in the next we will continue with the other complications of the gallstones as such. How to assess the hepatic hypersecretion? The hepatic hypersecretion is studied by liver function tests. Those who have high alkaline phosphatase content, they are categorized as a hypersecretion conditions. That's it, right? So that's about all the questions. So we will conclude today. And then, should we go for surgery in the stone is more than 3 mm? No, not at all. I would not suggest that. So I would be suggesting surgery if the stone is having, along with the stone, patient has a history of cholecystitis and the mucous membrane, this gallbladder membrane is more than 8 mm, thicker than 8 mm, then I would suggest surgery. Otherwise, we can manage medically. Right. So